Hi, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Sorry for the delay.
So
Right. Are we ready to start or
yes,
you're waiting for anyone?
so I think we can start first. Okay?
Right.
So first I open this today session with Kitab Al-Fatihah. Okay. Without further ado, I would like to invite Dr. Rasyidah to give a brief to lead the discussion on our topic today on hypertension in pregnancy. So please welcome.
Right. So let me just share my screen. Right. Can you guys see my slide?
Yes, Doctor.
Right. Wait, how do I do this? Wait, I saw my slide, but I cannot see you guys. Wait. All right. I'll just. So if I put the screen on slideshow, I cannot see you guys. But no one is opening the camera, so it's okay, I guess. Oh, sorry. Okay, so Assalamualaikum warahmatullahi wabarakatuh and good morning. Sorry for the delay. I'm settling the kids after coming back from the hospital. So first of all, I would like to thank the committee for inviting me for the session, Pro Exam Made Easy. So the topic given is hypertension in pregnancy. I will try to make it easy for you all. I think because this is a very common topic, very commonly seen in our pregnant mothers. So you guys would probably know most of the things that I will mention, but I'll try to put it in a way that you could see hypertension in pregnancy systematically to cover from top to bottom. So I've been thinking how to make it easy. So I'm thinking in the line of the questions of what, why, who, how, when, and where. So we'll go through one by one. What we'll be talking about what is hypertension, the definition of hypertension, how you classify hypertension in pregnancy, why instead of talking about the pathogenesis or pathophysiology, I think you guys will need to read up on the theoretical part of it. Instead, we will be talking about why is it important to know, to properly diagnose, to properly monitor, and to properly manage hypertension in pregnancy. Who? So we'll be talking about who are at risk for hypertension in pregnancy, especially who are at risk for preeclampsia, and what to do when we identify those with risk factors. So how we'll be talking about management, when, what to do during the throughout the pregnancy period, when to admit, where to manage these patients. So before we go on to the definition of hypertension in pregnancy, so I want you guys to like keep in mind this graph. Basically, this is the summary of the pattern of the mean arterial pressure of pregnant mothers according to weeks of gestation. So as you can see from during the first trimester, because of the physiological changes in pregnancy, the blood pressure is actually reducing up till 12 weeks, then down to second trimester, whereby it like plateaus at the second trimester. But entering the third trimester, the blood pressure will continue to rise again.
Sorry, doctor.
Yeah?
Sorry for interrupting. I don't think that we can see the graph. Okay, yeah. Now we can see.
Okay, okay. Can you see now?
Yes.
Yes,
Yes,
yes.
doctor.
Thank you, doctor.
All right. I think I'll wait. Because if I put the slide in slideshow, I cannot really see what I'm sharing. But if I put it like this, is it okay for you guys or is it small?
Okay, okay.
Okay, so I just share like this. Because when I put in slideshow, I cannot actually see the Google Meet. So I don't know whether you're seeing what I'm sharing. Okay, so we'll proceed. So the pattern, as I mentioned, it goes down from the first trimester and plateau at the second trimester. And then it goes up again in the third trimester. This is a physiological changes. So now we go on, the definition of hypertension. So you diagnose hypertension, of course, all of you know, when the BP is 140/90 or above, but it must be recorded on 2 occasions, which are 4 hours apart. But if the BP is severe hypertension, 160/110 or more, logically you don't wait 4 hours to actually repeat the blood pressure, because this is severe hypertension. Patient can get complications, especially intracranial bleed. So you will need to repeat in 15 minutes. So it is enough to make the diagnosis. So talking about blood pressure measurement, I think it is important to actually put in these slides a proper BP measurement. So this is what you need to carry with you, not only for the exam, but throughout your career as a doctor, as houseman, especially as a first liner, and throughout your career as a doctor, MO specialist, you will need to ensure that the patient has the proper BP measurement has been taken for the patient. So the gold standard is mercury sphygmomanometer, but nowadays we are going away from using the mercury sphygmomanometer. As you can see in the wards, we are using the automated device. There are other types of non-automated device other than mercury, the aneroid device. So the benefit of automated device as compared to the non-automated device is basically it is more not to say accurate, but it does not round off the numbers. So with non-automated device, so you have to measure the blood pressure and you all scalpel. So the clinicians sometimes tend to actually round up the numbers. So there would be some bias, and it will also depend on the sensitivity of those who take the blood pressure and your technique as well. Automated device, it gives you like exact number. It doesn't round off the number. It's actually avoid the bias, but it needs to be calibrated. But if you're using a non-automated device, again, the technique should be correct. You will need to palpate the radial pulse while inflating, and you need to note the last palpable pulse. So the initial inflation of the pulse should be 20 to 30 millimeter mercury above the palpable pulse. The deflation should not be really fast. It should be at the rate of about 2 millimeter mercury per second, and you will need to record the BP. You will need to record the BP to the nearest 2 millimeter mercury instead of round it up to like 145. You round it up either to 140 or 150. And in pregnant mothers, it has been recommended to use the Korotkov phase 5 for the diastolic BP, whereby the sound actually disappears. So the position is also very important. So you have been taught to take the blood pressure, whereby the arm you're taking the blood pressure should be at the heart level. So a patient ideally should be in sitting or semi-reclining position. I'm not sure whether any of you guys notice in the ward, usually done by nurses, even doctors. When the BP is high, patient is asked to lie in left lateral position and take the blood pressure. And if you notice, the blood pressure seems to be lower when the patient in left lateral position. This has been discussed in many papers. So basically, if you put the patient in left lateral and you take the blood pressure on the right arm, so the right arm is higher from the heart level. So the blood pressure will be lower. But if you take it on the left arm, the blood pressure might be slightly higher. So it is not recommended to actually put the patient in left lateral position to take the blood pressure, especially to take it from the upper part, upper arm, because it will give you a false low reading. So the patient actually has high blood pressure, but the blood pressure value that is read from the upper arm while the patient is lying on her side will be falsely low. It could be lower, about 10 millimeter mercury from the actual reading. So you're actually reading a lower BP than its actual value, and it could be dangerous to the patient. It has been recommended, if you want to take the BP in a left lateral or right lateral on the lateral positioning, you will need to take from both arms and to actually average the reading. All right, so this is very important because the left lateral positioning and taking the blood pressure from the upper arm has been done, like, I think, everywhere. So you don't want to have a falsely reassuring blood pressure measurement, while in actuality the patient is at danger from high BP. All right. I cannot see any of you guys. I feel like I'm talking to the laptop.
We hear that.
All right. So if you have any question, I think you can just stop me, because I'm not sure whether, probably a bit of interaction. If you want to ask at any point of time, I think maybe you can stop me at any point. And the proper cuff size is very important. I think 2/3 of the arm you would have heard. There's 80-40 rule, the 80% and 40% rule, meaning the bladder of the cuff. You know the blood pressure cuff, they have a bladder, inflated bladder inside. So the 80-40 rule is 80%. So the bladder should circle the arm about 80%, and the 40% is the length of the bladder. It should be 40% of the mid circumference of the arm. Or it could be from the size recommendation. So standard size, if the arm circumference is 33 centimeter, it's a standard size. If it's bigger, 33 to 41 centimeter, is large size. But if the arm is 41 centimeter or more, is the thigh cuff should be used. I think the challenge for a proper BP measurement nowadays is that more and more mothers are obese, and it's more difficult to get a proper cuff size. But it is important. Ensure the cuff is not undersized. If you cannot get a really good cuff for the mother, the best you can do is a larger size cuff rather than a smaller sized cuff. All right, so this is about proper BP measurement. This one you need to carry throughout your whole life. So what is hypertension in pregnancy? As I've mentioned, is 140/90 in 2 occasions about 4 hours apart. So you look at the pregnancy as a journey. So you go from early pregnancy until term. So we take cutoff point of 20 weeks. So before 20 weeks, there are chronic hypertension, white coat hypertension, and also masked hypertension. After 20 weeks, you have gestational hypertension, transient gestational hypertension, and also preeclampsia. And preeclampsia could be a new onset preeclampsia, or you could have a preeclampsia which is superimposed on chronic hypertension. So when you detect the blood pressure, as mentioned, before 20 weeks, it could be chronic hypertension. Most of it are essential, associated with family history, obesity, but 10% have underlying causes. So as in the table, so you will need to look for this secondary hypertension, secondary causes, the causes, underlying cause for the hypertension, especially if it's young hypertension, young women with chronic hypertension. But nowadays you are seeing more and more young women with actually essential hypertension. They have young hypertension and worked up, but there's no underlying cause, so it's actually idiopathic or essential hypertension. You also have white coat hypertension. 1/4 of women who with high BP before 20 weeks actually have white coat hypertension. So what it is when the BP is high in the clinic, but when we do monitoring at home, it is actually less than 135/85. However, previously it has been thought that it is benign, it is okay because the patient is actually nervous, so the BP is only high in the clinic. But it is not entirely benign, because 50%, half of women with white coat hypertension has been shown to develop gestational hypertension, and even 8% develop preeclampsia. So even women with white coat hypertension, they have normal BP at home, they have high BP in the clinic only. You have to pay attention to these mothers because they might develop gestational hypertension and even preeclampsia. Masked hypertension. So what is masked hypertension? So you don't see it. The hypertension is wearing a mask. How? The BP is normal in the clinic, but when monitoring at home shows that they have high blood pressure, this is also not benign. Half actually develop gestational hypertension. They have twice higher risk for preeclampsia than normal population. So it is a diagnostic challenge. Some women comes with complication of hypertension. Suddenly they develop preeclampsia or other complication of hypertension, but you're wondering why is she developing this, because the monitoring of the BP in the clinic is usually normal. So the patient might have masked hypertension. So these are the hypertension before 20 weeks. So 20 weeks and above, you have gestational hypertension. So the BP is normal before that, but after 20 weeks, the BP start to rise and you diagnose the patient with gestational hypertension. Ideally, you would need to have a normal BP before 12 weeks. As if you remember the first graph I've shown, the BP will progressively reduce in the first trimester going into second trimester. So you will need the actual BP before it actually goes down because of the physiological changes in pregnancy. But because if you have like the first BP is actually at 12 weeks, it could be the patient have like mild chronic hypertension before, but because of the physiological changes, it seems to be normal. But if you don't have that blood pressure before 12 weeks, at booking, for example, at 14 weeks, it's normal. Then it started to rise after 20 weeks. You still diagnose it as gestational hypertension. And remember those, we diagnose here gestational hypertension, transient gestational hypertension, and preeclampsia. It should resolve by 3 months, 12 weeks postpartum. So previously, it was taken as 6 weeks. The blood pressure should resolve by 6 weeks, but nowadays it has been extended. If the blood pressure actually resolved within 12 weeks, it is still considered as gestational hypertension instead of chronic hypertension. So what is transient gestational hypertension? You detect the BP high, for example, like once or twice, but subsequently, the repeated readings are normal. The patient was not on any medication, not on any treatment. So it is termed as transient gestational hypertension. And even in these women, you need to monitor because they have 20% to develop through gestational hypertension, and also they also have the chance to develop preeclampsia. Now, how about preeclampsia? So preeclampsia, okay, as I mentioned here, it normalized 3 months postpartum. So preeclampsia has been previously diagnosed with presence of hypertension, high blood pressure, and proteinuria. But we are seeing more and more women without proteinuria but having like target organ involvement, the maternal organ dysfunction, or even fetal involvement. So most of the guidelines have like gone away from the diagnosis of needing to have proteinuria to diagnose preeclampsia. So even if you don't have proteinuria, if you have hypertension with other maternal organ dysfunction or evidence of uteroplacental dysfunction, so you could diagnose the patient as preeclampsia. So we'll look at this one by one. So proteinuria, as you know, screening, you do urine dipstick. So 1+, it is predictive of significant proteinuria. So if you do dipstick for this patient, it is 1+, you proceed with quantification. Previously, we always use the 24-hour urine protein of 300 milligram over 24 hours, defined as significant proteinuria. But now we are moving towards doing protein creatinine ratio, whereby you will save time in terms of the patient will not need to collect the 24-hour urine. Instead, you can have one sample of urine and the lab will calculate the protein and creatinine ratio. So the level of 30 milligram per mole or more is considered as significant. Some use albumin creatinine ratio, but these are not widely used. But if it is used, 8 milligram per millimole or above is considered significant. So if you have high BP with significant proteinuria, it's preeclampsia. If you have high BP without proteinuria, but you have other maternal organ dysfunction, for example, for the brain, eclampsia, obviously, altered mental status, eye disturbance, blindness, persistent visual scotomata, clonus, severe headache, stroke. So you could diagnose the patient as having preeclampsia despite the urine protein is negative. Liver involvement, the transaminase is increased, depending, some say more than 40, some say more than 70, even if the patient does not have any epigastric pain. Kidney, if you have AKI, the creatinine level is 90 or more, or hematological complications such as you are seeing thrombocytopenia, evidence of hemolysis, or disseminated intravascular coagulopathy. So even without proteinuria, if you have any of these, you could diagnose the patient as preeclampsia. Or if the patient have hypertension, they don't have observed maternal organ dysfunction or proteinuria, but the baby is already affected. Uteroplacental dysfunction, you can see that's IUGR babies, or the doctor are abnormal, or the patient have stillbirth with gestational hypertension, so it is also termed as preeclampsia. As I've mentioned, preeclampsia superimposed on chronic hypertension. So you have the BP even before 20 weeks has been high, but the patient has no proteinuria, and the patient developed new proteinuria after 20 weeks. So you say the patient have preeclampsia superimposed on chronic hypertension, or after 20 weeks, the severity of the hypertension increases. You have preeclampsia features, or if the patient already have proteinuria as a result of kidney involvement from the chronic hypertension before 20 weeks, after 20 weeks, you noted there is worsening of the proteinuria. It could be that the patient having superimposed preeclampsia on top of the chronic hypertension. There are tests to be done to actually predict whether this patient have preeclampsia or not, because it is tricky, especially if the patient already have proteinuria before 20 weeks. So you want to know whether it is like worsening of the kidney because of chronic hypertension, or if the patient have actually preeclampsia. So there are tests, platelet growth factor, to actually predict. So these are the features of preeclampsia that need closer attention. So the International Society studies hypertension in pregnancy, actually not recommending us to use the term severe preeclampsia, because by saying severe preeclampsia, so you're saying the rest is mild preeclampsia. But you have to bear in mind, even mild preeclampsia have high risk to actually progressively or rapidly deteriorate in the patient. So they wanted us to like move away from putting the term severe preeclampsia. So they want the clinician to actually look at preeclampsia as one spectrum which can have a high morbidity to the mother, But there are features in preeclampsia patient that need closer attention. But others call this as severe preeclampsia. So it's easy to remember from head to toe approach. So you go from head, the brain, the eyes. So you have headache, blurring of vision, flashing before the eyes, nausea and vomiting. Although the features of the lungs is not included in the clinical features of the severe preeclampsia, but I put it here because the patient can have acute pulmonary edema as well. And even if the patient have hypertension with pulmonary edema, it could be as a spectrum of preeclampsia as well. Then you go down below to the liver, patient can have epigastric pain, increased transaminases. Then the kidneys, the patient can have oliguria, as mentioned, raised creatinine levels. And the blood cells, you can see the falling platelets, hemolysis, and the baby. You go to the uterus, you can see when it affects the baby, failure of fetal growth, and abnormal Doppler. So you go head from head to toe, so you will not miss the features of the preeclampsia that you will need to look for in the patient. All right. So we have covered what. So we go to why. Why is this important? Why hypertension in pregnancy? Especially, I've mentioned preeclampsia is important because chronic hypertension have 1/4 of them develop superimposed preeclampsia. They can have fetal growth restriction and they can have accelerated hypertension. And preeclampsia affect 2 to 8% of pregnancies. And gestational hypertension mothers, 1/4 will develop preeclampsia. They have higher risk to develop preeclampsia if they presented earlier, before 33 weeks, 34 weeks, and also even after delivery, the mother is at high risk of cardiovascular disease. So for the mother, high morbidity, high mortality, it has been shown that preeclampsia cause like 15% of direct maternal death. WHO reported 70,000 women die from preeclampsia each year, most common cause because of the complication from intracranial hemorrhage. Women with preeclampsia can have seizures, pulmonary edema, as I've mentioned, long-term cardiovascular complication. So not only it affect the mother, it also affect the baby. So the baby will have 5 times increased perinatal morbidity, mainly due to iatrogenic prematurity, because the treatment, as you know, for severe preeclampsia is to actually deliver the baby and also the placenta. So it's iatrogenic prematurity, which increases the perinatal morbidity. And confidential inquiry in the stillbirth and death of infant has shown that 1 in 6 stillbirth in pregnancy is associated with hypertension. And the babies, the pregnancy, the mothers can have a placenta abruptio, the baby can have fetal growth restriction, oligohydramnios, and even the baby, when they are born, in adult life, they are more at higher risk for hypertension and also stroke. So it has a very high impact on the mother and also the baby, high morbidity and also high mortality. So this is why this is very important. So we look at what are the risk factors for these women, especially to develop preeclampsia, because we can do something about it. So who is at risk? Most classify them into high or major risk or moderate risk. So if you have one of the high or major risk, or if you have more than one of the moderate risk, you start from PE prophylaxis. It has been shown that PE prophylaxis can reduce severe preterm preeclampsia, but not term preeclampsia. So if you have like hypertension in previous pregnancy, chronic hypertension, chronic kidney disease, autoimmune as listed SLE and APLS, type 1 or type 2 diabetes, and obesity, some classify it as high risk, some classify it as moderate risk. And moderate risk, primary parity, age of 40 years old, long interval. Some also showed a partner in less than 6 months, family history of preeclampsia and multifetal pregnancy. Our CPG Malaysia is similar to NICE guideline in terms of classifying the risk factors. So basically, you would want to start the patient on aspirin, 75 to 100 milligram. Ideally from very early pregnancy, from 12 weeks, but ISSHP said it can even before 16 weeks. And even if you miss the chance to give before 16 weeks, if you catch the mother before 20 weeks with this risk factor, you still can provide a bit of protection from the preeclampsia by starting the aspirin. And it has been shown that calcium in low intake population also help in reducing the risk of preeclampsia. In our Malaysian CPG, it recommends to give calcium. So I think probably it's because the Malaysian population is classified as a low intake population. So basically, if you don't know if the population is with low or high intake of calcium, it is beneficial to actually give the calcium. So basically, you have to identify the risk early in pregnancy. So start them on PE prophylaxis, aspirin, and also calcium. So how to manage? So we've seen what. So how to manage will depend on what type of the hypertension, when you want to manage in antenatal, intrapartum, or postpartum, and you will need to think of both the mothers and also the babies. So because in pregnancy you have two patients, every time you manage, you will need to think of these two and talk about where to manage the patient. So you want to manage the patient as outpatient, you want to manage the patient as inpatient. These are the things that you need to think about. So go to chronic hypertension. So the chronic hypertension is either the patient, you know the patient has hypertension before pregnancy, or the first time a patient was detected to have hypertension during the early pregnancy. So if the patient already have chronic hypertension and she is on medication, so what you need to do, if the patient in reproductive age group, you have to determine whether the patient is suitable to get pregnant or not. If she is not optimized for pregnancy, you will need to counsel for contraception. If she expressed her wish to get pregnant, you have to review a medication, whether it is safe in pregnancy, have to change the medication into a safer drug in pregnancy. You have to optimize the patient. You have to screen any target organ damage. But most of the women we see nowadays, they're already pregnant. The pre-pregnancy counseling is not as good as we hope for. So usually if you see the patient with chronic hypertension in early pregnancy, what you would do, you will need to review the medication. So see if the patient is on medication that is safe for pregnancy, ACE inhibitor, angiotensin receptor blocker, thiazide is not safe. It is teratogenic for the babies. You will need to advise for alternative. You do not stop the medication unless the BP is actually low, less than 110 or 70. And if the BP is actually more than 140/90, you will need to continue the medication if it is safe. If it is not safe, you will need to change the medication to a safer drug. Or if she is not already on antihypertensive, you will need to start the antihypertensive. So the NICE guideline gave first-line drug as labetalol, followed by nifedipine and methyldopa. But our CPG, Malaysian CPG, recommend methyldopa as the first line, labetalol as the alternative first line, and nifedipine as second line. So when we start the medication, what is our aim for BP? Our aim would be a tight control, so it should be less than 135/85. Previously, it has been recommended of control less than 140/90 is okay, but now we are going towards a tighter control, so less than 135/85. You have to remember this. Why? Because it has been shown that it can reduce complication of severe hypertension such as intracranial bleed. So common sense, how do you monitor? If it's well controlled, you go slightly larger gap, 2 to 4 weekly. If it's a bit of less control, you go for more frequent monitoring, you go for weekly. So it has been suggested as well to take baseline investigation at the diagnosis for a baseline, and depending on clinically whether to repeat it or not. So I've mentioned before, chronic hypertension, if you suspect preeclampsia from 20 to 35 weeks, you can offer the patient platelet growth factor to actually rule out preeclampsia. So
Doctor,
this is for the mother.
Doctor,
Oh yes,
just now for first line medication.
oh yes.
So in suspect, which one we put as the first line?
Suspect. Usually what is being practiced, because our CPG put as methyl-dopa. What has been I'm not sure in Susmet, but usually I'm talking about, because I've worked in Kelantan, I've worked in Selangor, I've worked in Pahang, but that is more than 13 years ago. But from what has been practiced in Kelantan, in Selangor, usually in Malaysia, what I see is that during the early pregnancy, methyl-dopa has been used as the first line. People are a bit hesitant to start labetalol during the early pregnancy because beta blocker has been shown to cause fetal growth restriction in babies. So clinicians are a bit hesitant to actually start labetalol in the early pregnancy. But if the patient already like 28 weeks and above, we usually start labetalol first. But in the early pregnancy, usually the first line we will start methyl-dopa. So that what I have been seeing so far. I'm not sure in Susmet. Usually in Susmet we saw like continuation of medication from the KK itself, so we will optimize the medication. But the general rule that usually is the early pregnancy before third trimester we start methyl-dopa first. After third trimester, then only the clinician is more comfortable to actually start labetalol. But why NICE is recommending labetalol as a first line regardless of the gestation, even in the early pregnancy, they also recommend labetalol as a first line. So actually, it's not labetalol itself has been shown to cause fetal growth restriction. Is other type of beta blocker. I can't remember which type for now. I will need to check back. But it's not labetalol actually, but they are extending the findings that they found in the other type of beta blocker to labetalol. That is why we in Malaysia actually a bit hesitant to start labetalol in the early part of the pregnancy. But because it is not directly labetalol that has been shown as a cause for the FGR, I think that is why NICE is recommending it to be started in the early pregnancy.
Okay.
Does that answer the question?
Yes.
All right. So for the baby, all right, this is the medication. This is in the our CPG, the latest one. Methyl-dopa 250 mg TDS up to maximum dose of 1 gram TDS. So labetalol of 100 mg BD. In the CPG, it showed only up to 400 milligram BD. I think this is the latest guideline, but we do give up to 400 mg TDS 3 times a day. And the nifedipine, 10 milligram TDS, you start at that dose and you can go up to maximum dose of the 20 milligram TDS. So as you can see, the methyl-dopa is the first line and labetalol is as the alternative first line. So we are a bit hesitant to start labetalol early in the pregnancy. Right? So for the baby, for chronic hypertension, CTG only if indicated. You will need to scan the baby for fetal growth, LIQUA, and also umbilical artery Doppler from 28 weeks. If it's normal, you do it every 4 weeks. But if there is abnormalities, you might want to do it earlier or more frequently. Then you go for gestational hypertension. So the latest guideline actually classified this into hypertension and severe hypertension. Previously, if you guys have the chance to see at the old guideline, they actually classify as mild, moderate, and severe. But now there is no more moderate, it's only hypertension or severe. So when the BP is 160 over 110 or more, it is classified as severe. So when do we admit the patient? Severe hypertension will need to admit the patient. If it's not severe, it's not routine, depending on the clinical condition of the patient. Antihypertension, if the severe hypertension, all will need to be started on antihypertensive. And for hypertension, if the BP is more than 140 over 90, you start the patient on medication because you aim for the tight control of less than 135 over 85. Previously, we start antihypertensive when the BP is persistently more 150 over 100 because we aim of a control less than 140 over 90. But now you start it earlier because you target the BP lower. How do you monitor? If the patient is severe and you admit the patient and the BP is still severe, you will need to monitor BP 15 to 30 minutes until the BP is less than 160 over 110. If it's not severe hypertension, maybe once or twice per week. When do you do urine dipstick? In severe hypertension, you will need to do it daily because these are the patients at high risk of developing preeclampsia. And for hypertension, which is not severe, you do the urine dipstick each time you monitor the BP. Sorry. Wait a second. Sorry for the interruption. Try to continue. So the blood test, when you diagnose, you will need to take the blood test. And if the patient does not have preeclampsia, you can take it weekly. Sorry. So that is for the mother. So the baby, you have to check for the fetal heart at every appointment. Ultrasound at diagnosis. If it's normal, but the patient have persistent severe hypertension, you will need to detect it 2 weekly. Why you do it more frequently? Because you want to detect the complication if the patient develops preeclampsia. But if it's not severe hypertension and the ultrasound at diagnosis is normal, you can repeat it 2 to 4 weekly when it is clinically indicated. Again, CTG is only if it's indicated. Now, for preeclampsia, you will need to actually do full clinical assessment of the mother, the symptoms, the signs at each antenatal appointment, because you want to detect if the patient need any intervention at that point of time, or if the patient have any concerning features associated with preeclampsia. So what are the concerning features? Again, I couldn't stress this enough. The diagram, you have to go from head to toe so you don't actually miss these concerning features in preeclampsia. Of course, if the BP is high, is severe hypertension, that's like biochemical hematological abnormalities, a sign of impending eclampsia, as mentioned just now. Here, the concern include sign of impending pulmonary edema, that is why I put the lungs as well, suspect fetal compromise, and other clinical concern. So if you have a clinical concern with patient with preeclampsia, you will need to admit the patient and manage the patient accordingly. Again, preeclampsia is also divided as the gestational hypertension, severe when the BP is 160 or 110 or more. So we'll need to admit all will need to be started on antihypertensive. BP monitoring, if you have preeclampsia, even though it is not severe hypertension, you will need to monitor the BP more frequently. Recommended is every other day. If it is admitted, so you will need to bring down the BP, measure BP every 15 to 30 minutes when the BP is okay. It is 4 times a day, 6 hourly or 4 hourly. How is it different in preeclampsia with gestational hypertension? So in preeclampsia, if the urine is already significant proteinuria, you will not need to repeat the urine dipstick. This will not change the management. Only the blood test, you will need to do it more frequently. In gestational hypertension, you do it weekly, but I know we're not doing it weekly here. It's because of resources. You go for clinical. If there is evidence of worsening, then only you repeat the investigation for gestational hypertension. But in preeclampsia, you have to do it more frequently. If it's not severe, you do it twice per week. If it's severe, you will need to do it 3 times per week to monitor if there is any concerning features as mentioned before, the HELP syndrome, hemolysis, elevated liver enzyme or low platelet, the worsening of creatinine or increased transaminases. And ISSHP also recommend taking uric acid because high uric acid actually showed a worse maternal and also fetal outcome. And fetal assessment, again, fetal heart at every appointment, ultrasound at diagnosis of preeclampsia, and if it is normal, you do it every 2 weekly. And CTG at diagnosis, and you only repeat if indicated. For example, if the patient have change in fetal movement, any vaginal bleed, abdominal pain, or maternal deterioration. So these are extra precautions to look for if the patient have previous severe preeclampsia, those needing delivery before 34 weeks due to preeclampsia, those with FGR babies in preeclampsia, previous IUD and abruptio placenta, the serial growth scan for the baby need to be done. So when do we deliver? So basically, the same rule applies to all. You would want to wait for term at 37 weeks unless there is an indication to deliver the baby earlier. As mentioned, preeclampsia, gestational hypertension has increased the rate of preterm morbidities in the baby because of iatrogenic preterm deliveries. So if there is no indication, you will want to wait for term at least at 37 weeks. In chronic hypertension, you will discuss delivery at 37 weeks. It is acceptable to deliver up to 39 weeks. In Malaysia, here we practice, if it's on medication, usually you deliver at 38 weeks. If it's not on medication, you can bring up to 40 weeks. So the ISSGP, they recommend to deliver at 39 weeks, regardless of whether it is on medication or not on medication. But I think it is individualized. You will need to look at the medication that she is on, how is the control, then you decide. But ideally, it must be after 37 weeks if there is no indication to deliver earlier. And even in gestational hypertension, if the BP is controlled, the fetus is all right, and there is no preeclampsia, the ISSHP actually recommended to bring the pregnancy up to 39 plus 6. So in preeclampsia, basically, if you diagnose the preeclampsia at 37 weeks, so the baby is already term, you want to initiate birth within 24 to 48 hours. But if it is preterm, you don't deliver the baby unless there is a reason to do so. So what are the reasons? You will need to identify the reason and also document the reason because of the high morbidity of the babies who are born prematurely. So if the patient has uncontrolled BP, difficult control despite being on 3 maximum dose of antihypertensive, of course, evidence of pulmonary edema, NICE put it as SpO2 more than 90. If there is eclampsia, of course, ongoing features of neurological features, headache, blurring of vision, nausea and vomiting, or progressive deterioration of the blood test, liver function, renal function, evidence of hemolysis and platelet, or the baby is already affected before 37 weeks, such as placenta abruptio, you cannot wait to deliver the baby. There's reverse in umbilical artery Doppler, non-reassuring CTG, or the baby has already stillbirth before 37 weeks. So these are the reasons that you need to consider delivering the baby before 37 weeks. Right. So intrapartum, of course, more frequent BP monitoring if it is severe hypertension. Otherwise, if the BP is all right, you can do hourly BP. adequate analgesia because you don't want the BP to shoot up during intrapartum because of the pain. Fluid limit, you don't want to overload the patient. Patient with preeclampsia have like leaky vessels, so you don't want the patient to go into fluid overload or EPO. Second stage, there is no routine recommendation to actually shorten the second stage. But if the BP is not controlled, the patient has severe hypertension, we will need to consider to shorten the second stage. Right? Okay, I forgot to mention, of course, patient with hypertension, for active third stage management, you give syntocinon instead of symptometrin. Right? So what are the medications in critical care setting? So this is important because there not much drug being used in pregnant mothers because of the safety. So oral medication, as mentioned, we have methyl-dopa as our first line according to our CPG. The alternative first line, labetalol, and also nifedipine as the second line. So you'll need to remember these drugs and also the dosing. And what are the medications in critical care setting? There's also not much drug. We have IV magnesium sulfate, antihypertensive that is used in critical care setting. You have oral medication, which is again labetalol and nifedipine. You don't use methyl-dopa in critical care setting for severe hypertension, whereby you want to bring the BP a bit more faster. So methyl-dopa is a bit of a more long-term control. So in a critical care setting, it's oral labetalol or nifedipine. Then parenteral antihypertensive, IV, you have IV labetalol as the first line and IV hydralazine as the second line. So when do you give IV magnesium sulfate? Obviously, if the patient have eclampsia, or if the patient does not have eclampsia, but you have severe preeclampsia, whereby you have like impending eclampsia features, or there's hypertension with concerning features of the hematological maternal organ involvement or fetal involvement, and you plan for delivery within 24 hours. So these are the women that you give IV magnesium sulfate, and you will need to remember the dosing for IV magnesium sulfate. You have through intravenous route, or if you don't have an IV line, you can give it by IV magnesium, IM, intramuscular magnesium sulfate, whereby the dosing is 10 gram, you give 5 gram each buttock. Why you give at 2 buttocks? Because the volume is a bit large, and it's painful to actually give the whole dosing of 10 gram at 1 buttock, so you give 5 gram at alternate each buttock. Right, so you will need to remember the dosing. IV magnesium sulfate, 4 gram is not 4 milligram over 10 to 15 minutes, and the maintenance is 1 gram per hour. Usually we give 1 gram per hour over 24 hours, and 24 hours is from the last fit or from delivery, whichever is later. So once you've got the intravenous access, it actually recommended to give intravenous. So the antihypertensive, all right. So when do you give oral? When you give parenteral, of course, when it's severe, you give 100 BP of 160 over 110, you give this antihypertensive. So when do you choose actually when to give oral or parenteral? A usual guide being used is according to the mean arterial pressure. If the mean arterial pressure is more or equal to 125, then suggested to give intravenous, because oral might not work at that point of time. So we'll need to look back at how to calculate on the mean arterial pressure. So if it's 125 or more, you will consider to give the intravenous instead of oral medication. Right? When you give magnesium sulfate, it is important to remember that you need to monitor for symptoms of magnesium sulfate toxicity. So the first sign that will appear is the loss of deep tendon reflex. So you start the patient on IV magnesium sulfate bolus, then you continue on with IV magnesium sulfate infusion. So you will need to monitor the mother. You cannot leave the mother be. You need to monitor the BP, You check the urine, you check the respiratory rate, you will need to check the tendon reflex as well. So what happens if the patient have signs of magnesium sulfate toxicity? For example, she have like respiratory rate less than 10. This is actually already too late. You will need to detect it even earlier. You will need to detect, because the first sign will be loss of deep tendon reflex. At that point of time, you will need to act already. So if the signs of magnesium sulfate toxicity, then only you take level of magnesium sulfate, but you will need to treat the patient immediately because the patient can go into cardiorespiratory collapse. So the treatment for magnesium sulfate toxicity, again, you will need to remember this. Calcium gluconate is 10% in 10 mils over 10 minutes, right? So this is the IV. There are different protocols according to the boluses and also infusion of hydralazine and labetalol. It is according to the local setting. So, right. I think, okay, what happened after delivery? So it doesn't end when the patient delivers. As mentioned, pre-eclampsia, eclampsia, the treatment is delivery of the fetus and the baby, but you do not stop there. After delivery, you will still need to look at the mother because, as I've mentioned, it has a long-term complications, cardiovascular complications, and the first 72 hours to 1 week after deliveries is the highest rate of the patient developing eclampsia. So in chronic hypertension or gestational hypertension, you can do it daily from day 1 to day 2, then every other day from day 3 to day 5, and subsequently when clinically indicated. In pre-eclampsia, you will need to keep the patient longer. So while inpatient, you will check the blood pressure 6 hourly or 4 hourly, which we are doing in the hospital. If not on medications, it's more or less similar to the chronic or gestational hypertension, once on day 3 to day 5, then every other day until it's normal. But if patient with preeclampsia on medication, so you know preeclampsia is more severe than gestational or chronic hypertension, so they will need closer monitoring, especially if the patient is on medication. So logically, those with more severe condition will need more frequent monitoring. So they will need daily or every other day monitoring up to 2 weeks at least, then continue on depending on the clinical situation. Another thing that you need to remember about medication, about methyl dopa. Methyl dopa will need to be stopped after delivery at least within 2 days. So after the patient is delivered, usually you stop the methyl dopa depending on the blood pressure, whether you start another medication or the medication can actually be stopped. But in preeclampsia, again, you do not stop the medication unless the BP is actually low of less than 110 over 70. So if the medication less than 130 over 80, you might consider to actually reduce the dosing. But if the patient is not already on any antihypertensive, you will need to start the antihypertensive if the BP is 150 or more. If the patient is on medication, you will need to review back the medication in 2 weeks. And at 6 weeks to 8 weeks, you will need to review the patient. Usually this will be done in the KK. Unless it is severe preeclampsia with affecting the organ, so probably it will be given appointment in the tertiary care as well. So about preeclampsia, as you know, preeclampsia, they have proteinuria. They can also have hematological abnormalities. So you repeat the investigation 48 to 72 hours, but if it's normal, you do not need to repeat that again. But the urine, you will need to check at about 6 to 8 weeks. If there is still proteinuria, you will need to review the kidney function at 3 months. If it is still abnormal, patient will need to be referred to kidney specialist to see if there is any impact on the kidney or the patient is actually having concurrent renal pathology during the pregnancy, which is rarer as compared to preeclampsia. So,
Doctor, Okay, so meaning after patient deliver, patient with
Mhm.
hypertension and pregnancy, so it
Mm.
depends whether it is a gestational or preeclampsia lah, whether we decide to discharge on day 2 or day 4 admission. Is it like that? Yeah.
Yes. Usually what we practice is that patient with preeclampsia, you will keep the patient at least 1 to 2 days. But if it's severe preeclampsia, depending on the setting, the local protocol, you actually keep the patient up to 3 days, or even at some places you keep at until 5 days, especially if the patient is started on IV magnesium sulfate. So as you know, IV magnesium sulfate is started on patient with, as you say, severe preeclampsia, or the patient already have eclampsia, and they have like other concerning features of preeclampsia needing them to be started on IV magnesium sulfate. So at some place we do keep them up to 5 days. Certain place keep them up to 3 days only. But even if you discharge the patient, regardless at day 3 earlier or day 5, which is later, you will need to do a high risk discharge, meaning the periphery, health clinic will need to be informed about the patient. We'll need to make sure that the patient have home visit done to monitor the blood pressure. So depending on the blood pressure, even though she was discharged on day 3 or day 5, it will need to be measured either daily or every other day, and will need to be reviewed back at clinic in 2 weeks, in the health clinic usually. So this is
Okay.
preeclampsia. Gestational hypertension or chronic hypertension, if the BP is all right, you can discharge the patient even on day 1. Because here in Malaysia, we have home visit, the nurses in clinic kesihatan, they have a list of patients. So they will do home visit for these patients. So even if we discharge the patient on day 1, and day 2, they will come to the patient's house to take the blood pressure. Usually it will be daily. Day 2, day 3, day 4, day 5, they will come daily, and subsequently they will come like longer gap depending on the patient's condition. But pre-eclampsia, you will need to keep the patient a bit more longer, depending if it's severe. So you probably keep the patient up to 3 days or 5 days, depending on local protocol as well. Does that answer the question?
Yes, 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 yes. Okay, thank you.
So, okay,
Doctor,
this,
I have a
yeah.
question.
Uh-huh.
If the patient is on labetalol,
Mm-hmm.
let's say the patient is preeclampsia on labetalol,
Mm-hmm.
then post delivery, when do we want to stop or when do we want to reduce the medication?
Pre-eclampsia.
Ah,
So as for according to the guideline, if it is pre-eclampsia, you actually do not stop the medication unless the BP is actually low. If the BP is less than 110/70, you actually do not stop the medication. If let's say the patient is on labetalol 200, so the BP is actually less than 130/80, you might want to consider reducing the dose. But that also depends on the how the BP you're monitoring in the ward. So when do you want to actually stop? It is not recommended to actually abruptly stop the medication. For example, that's why you need to review the patient. Usually, medical officers in of FMS in health clinic will review the patient. So we recommend to review the patient on antihypertensive at 2 weeks to actually adjust the medication. So depending on the BP trend monitoring over the past 2 weeks, whether the medication will need to be reduced in dosing, or whether it can, if it's already on minimal dosing and the BP is low, is about like 120, 110, 120 over 60 over 70, you might want to stop the medication instead. Or if it's like not the minimal dose yet, you want to taper the dose slowly and continue the BP monitoring. Does that answer the question?
yes, thank you, Doctor.
All right. So it's actually important to actually have good communication with health clinic. Actually, I think our health clinic service in Malaysia is very good. I only practice in Malaysia ever, but I don't know about other country, but I think our health clinic is very good in terms of they have a very good system to follow up the patient. Of course, they have coverage areas, so they will have the list of mothers who are pregnant. They will have a list of high-risk mothers. So only rarely these mothers like drop out of the radar. Sometimes like defaulted. The health clinic try to find them, but they are running away. So it is quite difficult. But usually they will know about these high-risk mothers, but the hospital will need to liaise with the clinic very closely as well. For example, if we are discharging these high-risk mothers, we will need to notify the health clinic. There are certain hospitals that have like high-risk group with the health clinics to actually inform about these high-risk mothers, to ensure that the follow-up, the home visit, the patient did not lost to follow-up in the health clinic. So I think it's because you cannot do this on your own at hospital setting. You will need to liaise with the health clinic to actually monitor this patient, because it is a long run follow-up process. As you can see, you need to review at 6 weeks, 8 weeks. In between, you have to see the mothers as well. So it is actually very detailed and very difficult, but I think our health clinic is doing a pretty good job so far. Right? So, I don't know if you see this. Can you see this? It's a bit small, right?
Small, yes, a bit small.
I'll just put on slideshow. If you cannot see, just inform, because once I put in slideshow, I cannot see what I'm sharing. All right, so this is what have been mentioned. If the patient have previous hypertension in previous pregnancy, so what are the risks on subsequent pregnancy? So any type of pregnancy, this previous pregnancy, the next pregnancy, they have like 20% risk to develop hypertension as well. If they have any type of hypertension or preeclampsia in this pregnancy, subsequent pregnancy, they have 7 to 14 risk to develop preeclampsia, gestational hypertension, and they also can have chronic hypertension as well. If this current pregnancy, they have preeclampsia and gestational hypertension, they have 2 to 3% to develop chronic hypertension. So it's a long run process. The mother is at risk, I think, for her whole life. And this is what I talk about cardiovascular risk. When the mother have hypertension in pregnancy, you have a long life risk of cardiovascular disease in terms of major adverse cardiovascular event, mortality, stroke, and also hypertension. So what we can advise the mothers is actually, this is postpartum, should be included in the counseling postpartum, but this is usually being left out, because I think there are so many things to actually counsel the mothers, but this is really important. We will need to start and continue on to advise the mothers on this, telling the mothers there is a high risk for her to develop cardiovascular risk in her subsequent long-term life. So we need to advise the mothers to get her advice to get at least pre-pregnancy weight over 12 months. We'll need to limit inter-pregnancy weight gain, and this is by advocating healthy lifestyle. And the mother will need an annual medical reviews. It does not stop at that. When you're delivered, you just stop at that. I think we are doing a pretty good job with gestational diabetes, whereby you have like gestational diabetes in pregnancy, then 6 weeks you do MGTT. If it's normal, you still continue with yearly surveillance. This should be done for hypertension as well. The patient will need annual medical review to see if she is having any of these complications. So I think that is all the information that I have on hypertension in pregnancy. So just to summarize, how would you approach a patient in terms of hypertension in pregnancy? So for pregnancy, we don't just start in the first trimester or early pregnancy. You go beyond that. You go before pregnancy when she is pre-pregnancy level. So this is very important. We are trying to advocate this pre-pregnancy counseling, I think, in many of the tertiary centers, although it is not at optimal level, but it is going there. So pre-pregnancy, if the mother is at a reproductive age group, you will need to look at the mother whether the health is optimum for her to go for pregnancy. If she is on chronic hypertension, you have to see whether there is target organ involvement, any complication, whether BP is optimized. If her condition is not optimized for pregnancy, you will need to counsel her for contraception. If the condition is optimized and she wants to go for pregnancy, so look at the medication. Is it a pregnancy safe medication? If it's not, you might want to change it to a safer medication. You want to optimize the BP before pregnancy. You want to start the mother on folic acid. But unfortunately, we are still seeing many mothers with chronic conditions getting pregnant without pre-pregnancy counseling, without optimization. So if these mothers come to you in early pregnancy, so we'll need to again look at the medication. Is it safe in pregnancy? Whether there is any screen for any target organ involvement. Start on folic acid early, at least up to 12 weeks. And the first trimester, you will need to confirm the date with correct dating, because you will need to monitor for the fetal growth, look for any evidence of fetal growth restrictions. So the correct dating is very important. Again, safe medication. So all pregnant mothers in the first trimester, you will need to identify the risk factor for preeclampsia. If she has one high risk or major risk, you start her on PE prophylaxis. If there are two moderate risk and above, you also start the patient on PE prophylaxis, aspirin from 12 weeks onwards, and also calcium. You put the patient on a combined test for trisomies, the first trimester screening, and then at second trimester detailed scan, because it has also been shown mothers with chronic hypertension have 20 to 30% risk of cardiac anomalies. And when she goes to third trimester especially, you will need to monitor for the onset of preeclampsia and also fetal monitoring. And needless to say, in hypertension, throughout the trimesters, you will need to monitor for blood pressure. Intrapartum, the BP control, analgesia, beware of the emergency medications, not to overload the patients. And postpartum, stop the methyl-dopa within 2 days. Others, you will need to monitor decide whether to stop, to continue, or to start medication. When and how frequent to monitor the blood pressure of the mothers according to the condition. How frequent to actually monitor the biochemically, and the long-term follow-up for the mothers, and also to advise the risk of the patient, risk of the hypertension in the mothers. I think that's all from my presentation. If you have any question.
Doctor, if patient with gestational age less than 37 weeks come diagnosed with preeclampsia, do we give dexamethasone directly or only give dexa when the patient develop any factors that require them to deliver immediately?
Okay, so you will need to look at why, the reason you want to give dexamethasone. So dexamethasone is actually for a coverage for the baby. You want to cover for RDS, you want to cover for IVH if the patient will need to deliver prematurely. So if the patient have preeclampsia before 37 weeks, you will need to see whether is there an indication for you to deliver the patient. So let's say it's a preeclampsia without any concerning features. The blood pressure is controlled, so you don't actually give dexamethasone to the patient because you don't plan to deliver. As I mentioned, all the patient you actually aim to deliver at 37 weeks for preeclampsia. You don't deliver before 37 weeks unless there is any indication. If you want to deliver the baby before 37 weeks, then you consider to give dexamethasone. So If according to NICE, you actually give dexamethasone up to 32 weeks, you offer up to 32 weeks, 32 to 36 weeks, you consider. So it's not a must, but you might want to consider from 32 weeks to 36 weeks onwards. So it also depends on your local pediatric support. So usually this will need to be discussed with your pediatric colleague as well, at how many weeks they prefer the baby to be covered by dexamethasone. But if it's less than 32 weeks, you want to deliver, of course you give. 32 to the 6 weeks, if you want to deliver the baby, for the maternal or fetal indication, you would consider to give dexamethasone. 36 to 37 weeks, there is no recommendation to actually give. At 37 weeks, actually you don't give anymore. Okay? Does that answer the question?
Understood, doctor. Thank you.
Okay. So depending on the condition of the preeclampsia, whether there's indication to deliver or no indication to deliver. No indication to deliver, of course you don't give lah. If you're worried, you think you will need to deliver the patient, so you give. Okay? Any other question?
Doctor, in the chat box there's a question. So the question is, how do we manage the patient with eclampsia apart from administering the magnesium sulfate?
Okay. So basically in eclampsia, so you will say eclampsia is a severe spectrum of the preeclampsia, already developed complication. So the management is, number one, the management of severe hypertension or severe preeclampsia, or when eclampsia has already occurred. So number one, you have to, if eclampsia hasn't occurred, you prevent eclampsia. Eclampsia has already occurred, you have to abort the eclampsia. So you give magnesium sulfate, number one. Okay. Number two, number one is with regard to eclampsia. Number two, you want to stabilize the BP. So you want to bring down the BP. So severe hypertension, you want to bring down the BP. So you give parenteral antihypertensive. And number three is deliver the baby. So there are three components for severe preeclampsia and eclampsia. So with regard to the fit, with regard to the BP, and the final treatment, how you treat is essentially delivering the baby and also the fetus. So if the patient already developed eclampsia, you will need to deliver the fetus. So that's the three components. It's actually not recommended to give diazepam to actually abort the fit if it's actually eclampsia. But if you don't have magnesium sulfate at that point of time, you don't want the patient to actually feed for so long, because risk of hypoxia to the mothers. So you can consider to give that if you don't have magnesium sulfate, or if you identify that for example, you already know that the patient have epilepsy. So instead of fitting because of eclampsia, so you might want to give other anti-epileptics. But if it's eclampsia, you are not recommended to give diazepam instead of magnesium sulfate. Magnesium sulfate is the recommended, but if you don't have the medication, you can consider to give that because you want to abort the fit. Right. I think I'm not sure whether the question is actually going towards other medication to treat the fit or the principle for the management. But the actual principle is the three with regard to fit, prevent or stop. Number two, control the blood pressure, and number three, deliver the baby. Right. I hope that answers the question. Any other question?
Doctor, I want to ask a question. How to choose between hydralazine and labetalol?
Okay, so labetalol is actually the first line Usually we go for labetalol unless if you have contraindication. For example, if the patient have like bronchial asthma, sometimes if very well controlled, we also give labetalol. But if it's not controlled or recent attack, we do not give. So instead you give IV hydralazine. But IV hydralazine is always the second line. And you need to remember in IV hydralazine, you have this reflex tachycardia effect. So sometimes it is recommended to actually like give some bolus of fluid to the patient before you give hydralazine, but it's a bit of a balance because, as you know, patient with, as I mentioned, with preeclampsia, they have leaky vessels. There's a risk of pulmonary edema, so you don't want to load the patient too much with fluid. So that is why you don't actually go for hydralazine as a first line, because the reflex tachycardia can be like severe tachycardia and patient can be symptomatic as well. But the first line is actually labetalol. I think most of the clinicians are more comfortable in using labetalol as well. Most of the protocol in most hospitals also advocate labetalol as the first line. And as mentioned in the CPG, the latest CPG as well, they don't put as hydrazine as the first line as parenteral antihypertensive anymore as well.
Thank you, Doctor.
All right. Any more question?
Doctor, in eclampsia, if patient have recurrent fitting, is there any consideration for the mode of delivery?
The mode of delivery. Okay. So in eclampsia, so you want to deliver the patient as soon as possible. The consideration on the mode of delivery will depend on the stage of the patient in, meaning if the patient had eclampsia in labor, you control, you abort the feed first, you control the BP, and then you will need to assess what stage of labor she is in. If she is already in second stage of labor, you can facilitate the delivery by instrumentation, for example, by forceps or vacuum. If it's already there, meaning perineum stage is already low, it's very feasible for instrumentation, then you go for vaginal. Otherwise, if the patient is not in second stage, if she's not in labor even if it's in second stage and it's not possible for the patient to deliver faster than you're doing cesarean section for the patient, so the mode of delivery is by cesarean section. That is eclampsia because the patient already fit. But if the patient have not fit yet, but a patient have pre-eclampsia. So you look at the factors. Preeclampsia, is it severe preeclampsia, severe hypertension in preeclampsia, for example. The BP is 160 over 110. They control the BP comes down. The BP is on control now. She's preeclampsia, but she is stable now. You have to discuss with the patient the options. You want to deliver the patient. It's either vaginal delivery, because she is stable now. Vaginal delivery, you will need to assess the Bishop scoring. If it's really unfavorable, discuss back with the patient. If she goes for induction of labor, you might not want to push it as much, like up to 3 prostin over 3 days. You don't want to prolong the pregnancy so much because it's already severe. You want to deliver probably within 1 to 2 days. You will need to discuss that with the patient. Otherwise, you will go for cesarean section. But it's not, if you say preeclampsia equals to cesarean section, you can still assess the patient individually and discuss with regard to induction of labor if she's not in labor. If she's already in labor, not yet fitting, you might want, then the BP is stabilized, symptoms of impending eclampsia resolve, the patient agreed to go for short trial of labor, you can go with proper monitoring. But if it's already eclampsia, as I mentioned, depending on the stage, in advanced stage, suitable for instrumentation, then you can go for vaginal. Otherwise, I would go for cesarean section. Right? Does that answer the question?
Yes.
Any other question?
Doctor, I just like to confirm my understanding. So currently the new guideline is for us to start medication when the BP is more than 140 over 90. So technically,
Yes.
all patient with hypertension in pregnancy, technically all of them are on medication, doctor?
When you put it that way, most likely kan? Betul lah bila you cakap tu. But we see patient without medication kan. So basically if it's persistently more than 140 over 90, I think you will need to individualize the patient. So let's say the patient come to you in clinic, so the BP is like 142 over 70. So you might want to see next setting, it's like 138 over 90. So I will not start the patient on medication yet. But if at every visit her BP is like 150 over 90, then the next visit 145 over 95, and the next visit 143 over 95. So I would start the patient on medication. So you will need to see the pattern of the BP as well and make adjustment individually and clinically. It's just a guide, because the BP will not necessarily be like both the systolic and diastolic 140, 90, 140. Sometimes the systolic is a bit 142, the diastolic is a bit like 83. So it's a bit under the borderline side. So I think it's just a rough guide, but you need to see the individual trend of the BP. And according to the trend of the BP, you will need to individualize and justify whether you want to start the medication or not. So because we want the BP less than 135 over 85. So if the BP, if she comes to you about 138 to 142, and probably the diastolic is about 85 to 90 plus a bit. So she might not need medication. So it's just a guide for you to like follow and to do judge and clinically see lah. Okay.
Thank you, doctor.
When you put it like that, macam betul juga. But individualize lah. We don't kata 140-90 start. Previously we used to say to start antihypertensive if the BP is persistently 150 over 100. So I guess it's the same if it's persistently more than 140 over 90. So you don't just go like one reading then start. Go individualize and see at the broad whole picture. Yeah. Okay. Any other question? Good question.
Doctor, I want to ask a question. In the case of fetus is IUGR, how would you manage the delivery? Is it like SVD?
Okay, you will need to look at the case individually. At how many weeks? How big is the baby? The LIQUA, the Doppler. If it's like premature, severely premature, usually you don't go for vaginal delivery. Probably less than 32 weeks. You know, at that point of time, if you induce the probability of number one, severe prematurity, let's say at 32 weeks. So you don't usually deliver babies at 32 weeks and below. So why you want to deliver babies who are severely premature at 32 weeks and below? Usually because the babies are already badly affected. For example, the Dopplers are already abnormal. So there are all the reasons here to actually go against vaginal delivery. Severe prematurity, induction will most likely to fail. And if you induce, the baby is already in a bad condition, the baby will go into distress. So you don't go for vaginal delivery usually at 32 weeks. Severely premature. If it's more of nearing term prematurity, you want to see the size of the baby. For example, 36 weeks, 37 weeks, you see the size of the baby. Usually if the baby is really small, I'm not sure if there's like a guideline on weight when to consider vaginal or cesarean section, but usually it take about 1.8 kilogram. If it's less than 1.8 kilograms, so the baby is very small, the risk for the baby to actually go into distress if the baby go into labor is higher. So usually less than 1.8 kilogram, you go for cesarean section. You don't want to stress the baby more intrapartum. And look at the Doppler as well. Usually if it's reverse or absent endosteric flow, the baby is, the placenta reserve is already not there. So even without stress, the Doppler is already abnormal. So you don't want to give contraction and stress the baby even more through labor. So abnormal Doppler, reverse, absent, endostolic, you also go for cesarean section. So you will need to look at the condition. If it's not severe premature, I think 35 weeks I will still go for cesarean section. You might want to consider delivery vaginally at about 36 weeks. It's not premature. The baby is not too small. There is no abnormal Dopplers. Even with LICWA, if it's severely oliguric, less than 3, with IUGR baby, if you want to go for vaginal delivery with induction of labor, you will need to be really careful, and this will need to discuss with the mother very thoroughly. So we'll need to look at the cases individually in terms of the gestation, the size of the baby, the LICWA volume, and also the Doppler, if there's any abnormal Doppler or not. So again, individualized, but these are the things that the points that you will need to look at to guide you in making decisions. I hope that answered the question. It's probably not.
Thank you, Doctor.
Yeah, it's probably not like point guide, this deliver vagina, this deliver cesarean, but just a guide on what is multiple factors. They'll need to look at all the factors and consider what are the risks to the baby if you go vaginally, and what are the risks. You want to reduce the risk for the baby. You don't want them to go into stress even more. All right? Okay. Any more questions?
Okay, so I think it's a very fruitful discussion today, and I'll open again if there is any more question. Okay, I believe there is most of the question already being asked, so we would like to give our sincere gratitude to Dr. Rasyidah for spending your weekend with us today, and thank you for the sharing session just now, discussion. So with that, I'll end the discussion today with Tasbih Kifarah and Surah.
Okay, thank you very much, everyone.
Thank you, Doctor.
Thank you, Doctor. Thank you, Doctor.
Assalamualaikum.
Salam. Thank you, Doctor.
Thank you, Doctor.